Yeah. So, dear doctors, we are really saddened to hear about the demise of respected Professor M. Das sir, who was a dedicated teacher of medical pharmacology, and we have pre-scheduled webinar on this drug therapy and adherence in Parkinson's disease uh, for that, and we have decided that prior to today's technical session, we'll have a 10-minute condolence meeting and we'll remember Professor M. Das sir. So first of all, may I request our mentor, the Director of Inovocare E-Academy, Professor Santanu Kumar Tripathi sir, to start this condolence meeting.
Good evening, everybody. So today we had a scheduled meeting, as you all know, that Parkinson's disease and drug therapy and adherence issues. But we are saddened to hear that one of our very senior colleague, Professor M. Das, a very renowned pharmacologist, and particularly a dedicated teacher in pharmacology, medical pharmacology, he passed away yesterday in Kolkata. And we decided that we'll have a very brief session prior to our technical session. So that's why we had also requested if some of our colleagues, because it's very hurriedly we had to organize this, and it's a very informal kind of arrangement. Later on, I think Indian Pharmacological Society, West Bengal branch, and also the national body, they may consider having a more formal condolence meeting. But today, before going in our technical session, we thought that let's have a very brief session remembering our respected Professor M. Das. And I would request, because this is the earlier scheduled program on Parkinsonism, it has a national audience. So I would request our colleagues from Kolkata and West Bengal, many of whom were actually students or colleagues of Professor M. Das. They will share their a couple of words in memory of Dr. M. Das. So I'll request them to express in English for the benefit of others who might be joining and who might not be understanding Bengali. So with this, I know that on behalf of West Bengal branch of Indian Pharmacological Society, we have amongst us Professor T.K. Mondal, who is a very senior professor of pharmacology, veterinary pharmacology, of course. We also have Professor Abhijit Hajra, who is currently the Secretary of Indian Pharmacological Society, West Bengal, and he is also a dedicated teacher in pharmacology. Professor Abhijit Hajra is there, who I think is also a student of Professor M. Das. One of our eminent speaker today, faculty today, Dr. Partha Ray, who he will be joining. He is a lead speaker today in our today's session. He happens to be also a student of Professor M. Das. I would request each one of you, we will have Dr. Sushanta Banerjee, who was the president of Indian Pharmacological Society national branch, national body, and also he retired as the director of medical education in West Bengal. I don't know whether Professor Sushanta Banerjee has joined. Another colleague of Professor M. Das, Professor Prashanta Mukherjee, was also supposed to join. Professor Shipra Bhattacharjee is supposed to join. If they have joined, and Dr. Neena Das, Professor Neena Das must have joined. So those who have joined, if you wish, just in say half a minute or 1 minute, if you can say your
can you
words.
hear me?
Yes, Prashantudami, I can hear you.
Okay, then.
So we will start with you. You are possibly the senior most colleague of Professor Das. Professor Prashanta Mukherjee, a very, very senior teacher of medical.
No, sir, Sushanto, sorry.
Sushanta Banerjee. Okay, I'm sorry. Sushanta, we'll start with you. Professor Sushanta Banerjee. Please, over, Professor Sushanta Banerjee. Welcome, sir. Please. And Dr.
Thank
Oruna Roy is also there. He will also say a couple of words. Now, Professor
uh,
Sushant Banerjee.
it's really very heartening and shocking news to get such a news of Professor Madan Mohan Das, the demise of Professor Madan Mohan Das. In fact, I had a long association with Professor Das because I still remember he was secretary of the then Calcutta branch of IPS for quite some time with another pharmacologist Jayasri Das, Dr. Professor Jayasri Das. From those days, I knew him when most of the meetings were usually used to hold in UCM, the then UCM. Now it is a Department of Pharmacology, IPJMER, and that was the beginning. And then subsequently, when I had some turmoil in the service, and then by some means or other, Professor Das was in medical college for quite long time, and then he was transferred to National Medical College, from where he retired. And I was out of service for some time due to some technical problems and other things, legal actions and other things are going on in those days. And after that, then after with court order, I again joined National, and then at that time he was my head of the department. And I remember we spent quite some time all together, and many things are coming in my memory, but the time is will not permit to say all the things. But one thing I still remember about Professor Das, when he used to ask the question before class. Many a times he used to ask this question, uh, and he used to tell everybody apni, whether it is student or it was a very unique thing of Professor Das. Whether it's a student or it's any staff, junior staff, everybody apni, and that was his unique thing. And he used to ask a question, a very interesting question. Dr. Banerjee, how many hours you study before a class? So usually I get confused and I used to, sir, 2 to 3 hours I used to study. No, 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 no. You should study for at least 7 to 8 hours before a class. And my dear friends, I tell you, I have seen this person. He used to study like this all the time. He used to open Goodman Gilman in front in the table, and I then came to know subsequently how Madan Das became Madan Das only by hard work, study, and everything he's in his memory, in his matha, in his head, everything. And anybody he used to ask any question, he always used to able to tell it immediately. Such was, this was possible due to hard work. I have hardly seen such a hard working teacher of those, and dedication and sincerity, I tell you. And perhaps nowadays it lacks. It lacks. He was a lesson. He was a lesson. Really, I could not follow him all the way he used to do. He used to study so hard, work so hard for the students, and he used to think about the students. It was tremendous, and a perfect gentleman, and everywhere, everything. It was really, it was a pleasure to work with him. And I could not get him as a teacher, but I used to listen how he used to teach, standing from outside the class many a times, because I always try to thought that I have scope to improvise myself. I could
Thank
not
you.
every time do it. With all these few words, I miss him like everybody, and pay my sincere regards to Professor Amindas, and tell that God that let his perhaps he has got two sons, Let them bear the pain of lost father, losing father. What is I know, I request and I pray to God to get to rest in peace. Thank you, Santanu.
Thank you, Shandana. Thank you very much. May I now request Professor Prashant Mukherjee, who is amongst us. He is a very senior person, I think almost of the same age, I don't know, or maybe uh, contemporary of Professor M.M. Das. May I request Professor Prashant Mukherjee, sir, to come up and say a couple of words?
Sir, we could not get him in the list, sir.
I find Dr. P.K. Mukherjee, his name is there. I don't know, maybe some other Dr. P.K. Mukherjee. Okay, let me now go to Dr. Abhijit Hajra, Professor Abhijit Hajra. He is currently the Secretary of Indian Pharmacological Society. Professor Abhijit Hajra, if you can hear us.
Yes, sir. Can you hear me?
Yeah, yeah. So very briefly, if you can say a couple of words here.
So thank you for inviting me to this forum where let me pay my tributes to Professor M.M. Das. He was my direct teacher in medical college. That was way back in 1989-90. 40 years have passed since then. And till I remember Professor M.M. Das vividly. The picture we are showing on screen, it's quite aged, but the impression that we have, that's still vivid with me. Let me say that in a few words that two things impressed us most. Sir's dedication to this discipline of pharmacology and Sir's emphasis on discipline from medical students. Those are two things I learned from him. Initially, when we went into the second professional MBBS in which we have to learn pharmacology, initially we were rather put off by the stern demeanor which Professor M.M. Das was known for. But later on, as we get more familiar with Sir, we realized that that's only the exterior, and inside was a perfect gentleman who was very, very friendly to us, very junior students. And let me say that the environment at that time in Medical College, Kolkata was very stimulating. In the department, Professor M.M. Das was there, Professor Shakti Padamaiti, S.P. Maiti was there, later on Professor Robin Chatterjee was there. And this whole environment is to a large extent responsible for my decision to dedicate my career to be a pharmacologist rather than a full-fledged clinician. So sir, wherever you are, rest in peace. And my condolences go to Dr. Taposh Das, his sir, who was just 1 year senior to us in college, and his family. That's all from my side.
Thank you very much, Dr. Hajra. May I now go to Dr. Neena Das, who has worked with Professor M.M. Das for some time, I suppose. Dr. Neena Das, if you are there.
Can you hear me?
Yes, please go ahead.
Thank you very much, Santanu, for giving me the opportunity to pay homage to Dr. Das. Really, I was very shocked yesterday when I heard about his sad demise. And I tried to contact Taposh. And after that, I had some talk with him. Actually, really, I worked sometime with Professor Das, and he was my mentor. Though I was not his student, I was colleague, but always I thought myself as his student. Without him, it was not possible for me to take the profession. Post-graduation was really possible for him. Every day he used to ask that you should, today you should read this chapter and tomorrow I'll ask you some questions. By that way, he really prepared me for the postgraduate entrance examination. And really, I was really very much shocked hearing the news. I thought that somewhere he is. Where he is, let him be in peace. And I am paying my homage with these few words, I want to conclude. Thank you.
Thank you. Thank you very much, Dr. Das. May I now request Professor Aruna Bhore. Professor Aruna Bhore is also from the same college, graduated from the same college as Professor Das, that is National Medical College, Kolkata. If Professor Aruna Bhore, if you are there, please come up, say a couple of words. Can you hear us, Professor Aruna Bhore? Okay.
That is there. Aruna Bhore sir is there, and also
Yeah.
sir, Pradeep Mukherjee sir is there. I think Dr. P.K. Mukherjee is in. So sir, also
Dr. Prashant Mukherjee, are you there, sir?
Can you hear me?
Yes, yes, yes.
Hear me?
Yes, yes. Please go ahead.
Can I speak? Yeah. First of all, I wish to thank you for giving me this opportunity. This is a very special occasion for me because really
So this
shocking.
is Professor Aruna Bhore. Professor Aruna Bhore is speaking. Yes, from Delhi. Yeah.
Yes.
Please go ahead.
Yes,
Please
yes.
go ahead. Yeah.
I hail from the same college that Professor Das passed out from, and I was his student in the early 70s when he taught us pharmacology. Totally at that time, pharmacology was quite different as compared to what it is now. And Professor who taught us how to look at pharmacology differently. That struck me at that point in time. Then I came after that, I moved to the specialty of pharmacology. I belong to regularly for an external examination for undergraduates. And I wish of being co-examined with him on several medical college. And he was very thorough gentleman, very knowledgeable, and he used to refer to even days. He used to refer to us as he used to refer to us as and his way of putting things across was really unique. And it is indeed a great satisfying thought for me that one of my colleagues and one of my classmates was treating him during his final days. I just got the news from him yesterday, and so today morning, he told me that he was remembering all his students, and he was surrounded by his family during his final moments. That must have been very pleasing, and I really pay my condolences to the grief family members. I feel like to give them the strength to bear this huge loss, and I soul rest in peace. Thank you very much.
Thank you.
Once
Thank
again
you,
for
Aruna
doing
Bhore.
this.
Thank you very much. There was some disturbance though in between. So may I now request Professor Prashant Mukherjee, if you are there, or else Dr. T.K. Mondal. Are you there, Professor T.K. Mondal? Dr. Topon Mondal? Okay. In that case, we'll just conclude. Before that, from my side, I am Dr. Santanu Tripathi. Let me say a couple of words. I would rather read out a message. Dr. Krishnangshu Ray, who is currently the president of Indian Pharmaceutical Society West Bengal branch. So he could not stay here, but then he had forwarded a message on Dr. M.M. Das. I have edited that a little, and I am just reading that out on behalf of Professor Krishnangshu Ray. Dr. M.M. Das had graduated from Chittaranjan National Medical College in 1959. He had his house job in medicine under Professor Somir Biswas, who was his mentor, and Dr. Somir Biswas edited Dr. R.N. Ghosh's book on pharmacology, and Professor M.M. Das later also edited the same book. Professor M.M. Das had his post-graduation in pharmacology from University of Calcutta, possibly in 1969. Professor Das was a renowned teacher in pharmacology and had a teaching career of more than 35 years in many medical colleges in West Bengal and served as the head of the department in several of them. Professor M.M. Das authored 2 pharmacology books, one textbook and one handbook. Both were very well accepted by the students. Professor Das delivered the Colonel R.N. Chopra oration in 1995 at Indian Pharmacological Society annual conference at Patiala. A popular teacher, an able administrator, and above all, an amicable personality endeared by all around, Dr. Das shall be remembered by innumerable students of his and his colleagues also. He had 2 sons, elder one a gastroenterologist and a daughter. May his soul rest in peace. Our heartfelt condolences to his family. Om Shanti.
Professor Tapan Mondol is here with us.
Professor Tapan Mondol, are you there? If you can say a couple of words. Professor Mondol is a very senior member in our society. So,
actually, I met him when I joined as a member of Indian Pharmacological Society and in several meetings of the general body of IPS West Bengal branch. And at that time, I knew him, and I knew him as a good personality and a simple person, an affectionate person, and gentleman, thorough gentleman. This I know. So this is a great loss to the Pharmacology Society. So I pray to Almighty rest in peace. Thank you.
So before we conclude, Professor Tripathi, just a brief proposal that if you help me out or Professor Neena Dash helps me out with the facts, because Neena Madam is in contact with Dr. Taposh Dash, we can just cross-check the facts and write an obituary of Professor M.M. Dash to be published in the Indian Journal of Pharmacology. So
yes, I'm trying to gather the information. And
I can take that responsibility with your help.
Yes, of course, I'll be sharing with you. And now, of course,
if there is any need, I'll surely help you, Santanu.
Yes, of course. Yes.
If the facts regarding his education and career can be checked with Dr. Taposh.
Yes, I can do it.
Right. So, of course, as I told that in our technical session today, the lead speaker is Professor Dr. Partha, who is a neurologist.
Can I say a few things about Professor Das?
Before Professor, okay, now over to Professor Ray to say a couple of words.
Yes.
Incidentally, Professor Ray is also a student of Professor M.M. Das.
Yes.
So,
yes. I was looking at Sir's eyes as the picture was on the screen, and it took me back to 1986, 1987, when I was his student with the 4th and 6th semesters. It was a wonderful time because we had just entered into clinical medicine. We were going to the wards, and there was pathology, pharmacology, PSM, and FSM to juggle around. And I think everybody knows that the second MBBS is the most busy period of anybody's undergraduate curriculum. There's so much to do and so many new things happening. First of all, I had to extend my condolences to the family, to Taposh, who was our junior, his other son and daughter, and Mrs. Dash. We are very sad today to hear of Sir's demise, but it's a cycle of life. We had all have to bow our head when our time comes. I have very pleasant memories of him. He was a very dignified gentleman. His knowledge, which we always knew was from Goodman Gilman, cover to cover, was absolutely robust, and that impressed us. He was a very academic sort of person, exuded that through his personality, a real iconic figure. We were actually scared of him, to be honest. Today we are actually feeling sorry, but the last thing we wanted was to be anywhere near him, because anywhere near him meant imminent danger, because we had not studied for half an hour the prescriptions that he used to catch us on. and anybody who was there in the afternoon on his table, we had to go into his room by the window, and if the most people would come out in tears. But we didn't realize at that time that it was all meant for our own good, because we hadn't done the work, and he was simply trying to drill in basic tenets of pharmacology into all of us, which was so very important. So he was a real stickler for drug spellings, doses, how many times. He also knew a bit of Latin, because in pharmacology, we did not know Latin, but he knew quite a few Latin words for the pharmacological equivalents. So that was very interesting. But I can say for myself, I was very scared whenever he was around us, including when we were doing old-fashioned pestle and mortar ointments and those, concoction that was being done as part of a practical experience at that time. So, I mean, what can I say? He had a very strange smile. And to this day, I was looking at his picture and I still cannot decipher what he meant at that time. But now that I am older, I think he was enjoying the fact that the students were slowly learning, and he never raised his voice. He was very soft spoken. Never ever have seen him losing his temper, and his eyes had that piercing bright look, and that's there in the picture as well. So we maintained that for 37 years after I saw him. That's a real, there was no evidence of any cerebral strain that I can see in the picture whenever that was taken. I won't take more time, but I'm very sorry that he's with us no more. But as I say, it's a fact of life. May his soul rest in peace. May his spirit inspire us to become like him, as well as sincere, dedicated, inspirational to students who are very big pharmacologists and leaders of education across the world and in India. And once again, I extend my condolences to the family and my deep respects and pranam to the departed teacher, who has been a beacon of light and knowledge. That's what we all come to worship and pray for all of us.
Thank you. Thank you very much, Professor Ray. Before we go to the technical session, just a couple of minutes from my side. I graduated from Arjikor Medical College. I still remember when before that pharmacology examination, we were actually praying, at least Professor M.M. Das should not be our examiner. Okay, that was one thing I remember. Secondly, when I did my MD from BHU, Varanasi, as I came back, I learned that Professor M.M. Das had spoken to my teacher, Professor Sholil Bhattacharya, that he wants me to his department. So I was asked to come and meet him. So I came, and I actually met him at around, say, 11 o'clock in the morning. He made me sit in front of him for almost 3-4 hours, and because he won't leave the department before 4 o'clock. Okay, at 4 o'clock he took me, and he had to make me follow him on walk to Writers Building. Okay, took me to Writers Building. That time the director of health services was Professor Shitesh Lahiri, was another eminent pharmacologist. So he was his senior colleague at a time, at some point of time. So he took the advantage of taking me and introduced me to him, Professor Shitesh Lahiri, and requested him that I should be taken to his department. Although it didn't materialize, I had to wait for an year or so, but then I had the opportunity to rather professionally interact with him, and I found him a perfect gentleman and a very affectionate person, a very mutually, he knew how to actually be mutually respectful. Okay, I had a huge regard for him in the field of pharmacology. After he retired, of course, we didn't in very close touch for quite some time, but his smile always I really liked. Okay, he was a great personality. I really miss him now. So we all wish that his soul rest in peace, and let the Almighty give the strength to his near and dears to bear this loss. So thank you very much. Thank you, everybody. So now we request Dr. Shambo to take over, and I would request all those who joined for this condolence meeting. You are all welcome and invited to the next technical session, but it's up to you because it was not really scheduled. If you wish, you can stay back. We'll be very happy. The session that is we are going to start. Of course, the session also has to be made a little shortened now. That is drug treatment of Parkinsonism and treatment adherence. So those of you who wish to stay back, you are welcome. Thank you very much. Over to Dr. Shambo.
Thank you, sir. Thank you very much. So as if we just go by the book written by Professor Das sir, so one unique thing in that book is in the front page, there is no name of him. So it was written for the students of the second professional MBBS. Like that, we can, even in the backward page also, there is no description about the author also. So one thing that is written in the book in clearly, that is this book is dedicated for the students. So I think with that passion, we should dedicate today's academic session to this great personality whose life was devoted towards the medical students. So with that, may I request Professor Mrinal Kanti Roy sir, today's chairperson. He is a very renowned face in the field of medicine, neuromedicine, and cardiology also. So may I request sir to chair today's session. And with that, we are also really fortunate to have Professor Santanu Tripathi sir, who is a renowned clinical pharmacologist in the country. So to chair the session, and we can start today's academic proceedings. Over to chairperson, sir.
Before we proceed, Professor Mrinal Kanti Roy sir, we are sorry that we have kept you waiting for so much time.
No, not at all. Not at all. Because
this was actually not scheduled.
Santanu, I did not tell anything, but
Sorry,
only one line actually that so I had an opportunity to meet sir once while I was doing my MD. And actually, the ways various speakers have told about him, the first thing which struck in my mind at that point of time was that he is an epitome of discipline, punctuality, because I was a little bit late prior to this appointment. So he asked me whether I was reading or not. So I told him, no, sir, I was stuck up in the jam. He told me, you cannot be successful in life if you get stumped up in every step, because it is your first day. But I tell you that when you come to this class, it should be in the right time. So that was my first encounter. After that, I find a lot of things in this gentleman that which made our paved our path of the future in the right directions. With bow down, and I wish and I pray to Almighty for the eternal peace to the departed soul and deep condolences to the members of the family. Thank you. Shantanu.
Thank you, sir. Thank you. So, Professor Rai, please take over now. Please lead the
without wasting time. Now, today we have got three speakers today in our list.
Right.
As Shambo has told me, that the first topic will be covered by Dr. Partha. So you all know Dr. Partha. He is at present the professor of neurology in Liverpool. I am not going to tell a lot of list about Professor Ray because he has got a number of accolades to his credit, and he is regular now, almost last 1 year. He is regularly attending all the functions and conferences and interacting in such a way that his academy has come up in a very good way in front of us, and all the students are being benefited by his presence. So without wasting time, I will request Dr. Ray, please start your deliberation of the topic. I am a little bit, I am cut shorting or other things. So please start so that we can be in time.
Yeah. Right. Respected Professor Mrinal Rai, respected Professor Santanu Tripathi, our chairpersons, my colleague speakers, attending dignitaries, namaskar to all, and most importantly, our students. the topic that has been given to me today is on the clinical diagnosis and therapeutic approach Parkinson's disease. It's a wide topic, and I've been given 20 minutes to cover. I'll try to do as much justice as possible to it. I start with a heavy heart because the person who introduced me into clinical pharmacology is no more as of yesterday. There were other teachers who have followed him, and we all here as a group pay our condolences and respects to Professor Dash. With those words, yes, as Professor Mrinal Kanti said, I have been in England for quite some time, and it's possibly time to come back home. I have some conflicts of interest in that the topic I've been given today, I've actually covered in a series of 5 videos on Parkinson's disease and atypical Parkinson's and ataxia, which I would recommend the students to go through, because today will be an abridged version of those topics. You can click on the link and go to those sites. Please, for patient confidentiality, privacy, and dignity, avoid taking any pictures. Now, the preamble is that, Parkinson's disease, we all talk about James Parkinson. And my slides are a bit busy because I'll be distributing the slides after the talk for the students. But he was a surgeon who made some very important observational analysis of what he saw in his neighborhood. And that came from the essay of the shaking palsy. And there's a very good description, and it shows how much we see in our patients. And if we do that in a meticulous manner, day in, day out, we'll be able to find a lot of important findings. Today, the technology has taken over. Clinical medicine has taken a bit of a backseat, but this particular disease shows how much observational analysis and listening to the patient and communicating with the patients can help in taking the field forward. Now, I am Indian, and I have been reading the Shushruta Samhita and the Charak Samhita. And as you can see, Shushruta and Charak, and we do not know actually whether there were single people or whether there were clans or there were colleges of medicine practitioners thousands of years ago. And if we go through those books, then we can see as to how Indian science, Indian surgery, plastic surgery, rhinoplasty operations were so very advanced about thousands of years ago in the Mahabharata period. So that's something to really look back on and go through. We have all taken the Hippocrates Oath, but how many of us here know that Shushruta also had codes of conduct for teachers as well as students? I read in the Wikipedia that there was an existing Shushruta code that we Indians have from a very long time ago. Regarding the biochemistry and the chemical pharmacology, the Mayas and the Incas had lots of plants that were of medicinal value. And that leads me on to our Ayurveda, which we have not been researching well enough or neglecting, to be actually fair and honest. And that's something we need to really look back on for new drug development. These are the 2 books which actually are sitting next to me, and I thought I'd actually show you the pictures, that these books are actually available in English by 1907 print from Kunjo Lal Bishop Grohoratno, and this is from an English person. There's translations, and I'd recommend our students at least go through it. Now, going on to the topic now, I'll be going fast a bit because of the limitations of time. Now, Parkinson's disease and the neurology behind it. Now, it all started from the understanding of the pathogenesis, and that's based upon the Brack's stages of Parkinson's disease. It is actually believed that the disease spreads from lower down here. Let me get my pointer up. Maybe it won't allow me it. 1 moment. There's pointer options here. Laser pointer. Yeah. So the disease starts somewhere here in the medulla oblongata, and then proceeds rostrally to go up here, and then spreads throughout the cortex, neocortex. And that takes a lot of time to take place. There is another view I will be adding here, that it's often felt that the disease starts in the gut and spreads to the brain. And there's another view which holds that the disease starts in the brain and spreads to the gut, the enteric nervous system. So the discussions continue as to where the disease starts in the Parkinson's disease. Now, the classic findings of Parkinson's disease are these lovey bodies, and I've given you an H&E stain. and another ubiquitin stain that shows the presence of these bodies within the brain that identify Parkinson's disease. There are two groups of disorders: Parkinson's disease, multiple system atrophy, dementia with Lewy bodies, which are synucleinopathies. And these are the tauopathies. These are proteins that are deposited in the brain in these different disorders, and they are all linked up apart from pathologically. Now, these are pathological specimens which show the normal findings in a normal substantia nigra, where you see the black coloration of the melanin pigments, compared to that of a Parkinsonian patient, where there is no, basically there's diminution of the melanin pigments. There's lots of neurotransmitters that we'll be discussing in the from Shambo, and we are basically relying on dopaminergic hypothesis for the neurotransmitters. This was a slide that really floored me, because I did not know that the Parkinson's pathogenesis was so complicated. But believe you me, there is oxidative stress, mitophagy, energy depletion, mitochondrial hypothesis. A lot of pathological processes are at play, and the references are down here, so I won't have the time to go through them, but this is well worth a read from not too long ago. There's lots of genetic influences on Parkinson's disease, and new genes are becoming identified. There's, of course, the degenerative Parkinson's disease from aging, and of course, the pathogenesis that I was talking about, including oxidative stress and autophagy and all the rest of it, all leading to the Parkinson's disease. To the interested, I would recommend these. Now let's go to.
Sometimes you get no response.
Go to a patient.
Sometimes you get no
disease.
Response from Cinemed.
You can see out here.
And sometimes the
sure
latency from the time you take the Cinemed.
Yeah, it sounds scary.
To the time you notice
so
any
here is
improvement,
Professor Joe Jankovic's
no
voice.
Sometimes you get no response from Cinemed. Is that correct?
Tremor.
And sometimes the
tight.
latency from the time you take the Cinemed to the time you notice any improvement
He's on
may take what, an hour or two?
Yes, anywhere from.
And here you can see that he will soon.
The patient has classic signs of Parkinson's disease in his off state, including a coarse pill-rolling tremor, stooped posture, hypophonia, poverty of associated movements, and masked face. He has difficulty getting up from a chair and can only take a few shuffling steps before flopping back down into his chair.
Now he's receiving apomorphine.
So your wife is now going to give you 0.5 milligrams of apomorphine. And could you stand up for me? Okay, and then walk back and forth, okay?
A subcutaneous injection of apomorphine ends his off state in a few minutes.
So I did manage to show you the effects of Parkinson's disease. The next few slides, videos, show the very debilitating nature of the condition as we see it: bilateral, this symmetric, slightly asymmetric tremor, mainly peripheral, in an elderly person. The next one is the bradykinesia.
The patient's upper limbs have normal volitional mobility.
Okay, now let me see you walk a little bit. Let me have you stand up for us. Okay. And try to walk to the wall there.
He is able to arise from the seated position with little difficulty. He stands with his feet far apart.
No, just walk as you normally would.
He has difficulty getting going and freezes up while trying to turn, especially when trying to move his right foot. He needs to brace himself against the wall to regain his stability.
And keep coming back.
His arm swing is less on the right than the left.
Okay, now turn around and go back one more time.
This is where I usually started forward, lean a little forward, and the feet don't go, and then fall forward. There we go.
A lot of
He freezes when he shifts his attention to the speaker.
Okay, and okay, so whenever someone talks to you, that really interrupts the walking. Is that correct? Okay.
When stepping over an obstacle, such as the protruding part of his cane, he can avoid freezing. Imagined obstacles may work as well.
Keep going.
Turn around, go back.
Yes, sir.
Which way or what? I don't know. I gotta use it. Takes me a step over. That works. Sure does work.
right. In the interest of time, I'll carry on. That again, the same person we saw a little bit earlier on. Here we are seeing basically, we saw in the last video, start hesitation, festination, because the person had difficulty starting off the movement. Here we are seeing the great difficulty the lady has in turning around a certain point, en bloc turning, we're calling it. Here we are seeing the lack of postural balance that this person has, and the inability to be able to hold the balance when pulled from the back. So I just introduced those videos to show you the motor disturbances in Parkinson's disease. Well, you can see the list as is there. There's a swallowing difficulty, some dystonia where the limbs go into a fixed position. We have seen freezing, we have seen gait impairment, it's slow. There is also the speech defect where the voice is low volume. And there's imbalance and falls, we saw that, micrographia, resting tremor, and this typical stooped posturing. Now, I showed you the Braak's classification where all of this is predated by a lot of other symptoms which precede the motor symptoms. There are sleep problems, there is smell problems, there are psychiatric problems, and of course, the autonomic nervous system dysfunctions that precedes all the motor disturbances, because the parts of the medulla and other parts of the brain before the basal ganglia are affected get involved by the Braak's progression of the synuclein pathology. Non-motor disturbances in Parkinson's disease has not been very well understood till about 15 years ago, when one of our ex-students from Calcutta Medical College, Professor Kollol Rai Chaudhary, actually took an interest in the mid-90s in this disorder. And now we have learned to associate all these symptoms as part and parcel of the Parkinson's disease. And you can read the slides here. I'll be releasing them later on. As the non-motor disturbance of Parkinson's disease, which we have not identified for a very long time. We were very focused on dopamine and the motor. Now, whenever patients come to us with these symptoms, as we just now saw in the videos, are they all having Parkinson's disease? I mean, the idiopathic Parkinson's disease? Of course not. There is a large number of conditions, as I enumerate out here, which a neurologist and a general medicine person will have to think through as to which of these is possibly the alternative differential. Now, I just put up a few slides to show you again here some eye movement problems. Usually, as you all know, we can move our eyes in all directions. But watch here, the lady has difficulty in moving the eyes in an up and down, up in the vertical direction, although she's able to move the eyes when the head is moved up and down. So that's progressive supranuclear palsy. And then again, if you look at the other one that we have out here, it's a bit of a subtle video that we have put up here on the 6 years. These eye signs may not be present at the very beginning. And you see this patient may well be misdiagnosed as having Parkinson's disease in the way you can see them. She's moving around. We saw the elderly lady moving around slowly. And here she's moving her eyes. It seems a bit slowly. Watch the video, but 8 years on, see what's happened. It's all, the pursuit is is slightly broken, as I can see it, but see the vertical. The vertical is definitely impaired. Vertical pursuit movements, the saccades she's doing at the moment, up and down is being called out for her, and the glabella tap. So the reason I'm showing you, watch this as well, apraxia of eye opening. She cannot open her eyelids because of apraxia. She'll apply a trick and then manually open the eyes. So these are features of progressive supranuclear palsy. The reason I'm showing you these pictures is that Parkinson's disease is not a straightforward diagnosis. It's a clinical diagnosis, but eventually it's a pathological diagnosis, because in the best of hands, out of specialist movement disorders, seeing decades of movement disorders and Parkinson's diagnosis, there is a 25% error rate. And unless we see synuclein pathology and Lewy bodies, we cannot diagnose Parkinson's. So that's the problem behind it. Another common condition which we see is vascular Parkinsonism. Watch this video because I think this is a better one. Lots of patients having diabetes.
This gentleman is sitting in a wheelchair.
And hypertension.
How long has it been going on? There is reasonably normal facial expression and absence of tremor.
Describe it to me. What is actually the problem? Describe it a little bit more in details.
The walking
Could not start. Could not start. What happened when you start? If you can't get start, what happened?
What happened?
If you're able to start, are you able to continue walking?
Once I started, I can continue, yes.
Okay. Do you have fall? Have you been
So
falling?
once he can continue, has difficulty starting.
Okay. Do you fall forward or backwards?
Forward, because I want to jump up.
Yeah.
And my right hand, my right leg could not.
Yeah.
It's important because lots of vascular Parkinson's are diagnosed as idiopathic Parkinson's, and you will see why. These are close mimics of Parkinson's disease. Hence, I'm showing you a few representative conditions which
he's able to carry out fairly normal, rapid finger tapping movements, open, close movements of his hands, supination, pronation movements of his hand on his thigh.
With your right hand, can you tap like this for me? Big movement, okay?
there is not much in way of bradykines here. There's no decrement I can see there.
Do like this for me, please. No, try to.
Heel tapping movements are also relatively brisk bilaterally.
So these are differences how we neurologists and medicine people differentiate Parkinson's
He's able to get up
from
from a chair
other conditions
with
which
minimal
look like
difficulty with his arms
Parkinson's.
crossed over his chest.
And that's the
However,
objective.
his gait is significantly abnormal.
You see a difference.
Stride length is very short, very tentative. Gait is shuffling with reduced elevation of his feet from the floor. And there is also an occasional freezing of gait.
Okay, what about if you count 1, 2, 3, start? Does it help if you count 1, 2, 3?
He's using sensory cues to get him going. Like we saw the man earlier on using a stick and stepping over it to get over the ignition failure or start hesitation that we had there.
1, 2, 3, start. Let's try to walk. Want to see you walk a little bit more, okay? Try. See what? 1, 2, 3, and so. Okay, turn around for me.
When asked to turn, he hesitates, appears to be somewhat stuck to the floor, and takes a series of very, very tiny steps to pivot in place.
I recommend him that what will be useful for him to have a laser pointer in his hand and to point the red laser onto the floor to initiate his gait. That would be a good trick for him to use. Yes, please. Yeah.
So they're talking about using a laser pointer and the patient stepping over it.
Sometimes listening to the music that gives the signal.
Music therapy, stepping to a metronome helps people
Now, when you want to
walk.
start, I want you to try to point the light onto the floor. I know that this light is not very
In the
strong,
interest of
so-
time, I'll move on because I leave these videos for afterwards. Let's move on to the next slide. Yep. So we have seen the PSP. Let's show you something called corticobasal ganglionic degeneration. The reason I'm showing you these pictures is that it's very easy to start to treat a patient for a condition they don't have. And I don't think that's good medicine. Sorry, I can't get to that particular slide. Let's move on to the, one moment, sorry. Yep. I can't show you this slide, or should be able to. No, it's not doing it. Right. Okay. So we showed you some mimics of Parkinsonism, and there are other disorders which can also come with Parkinson-looking symptoms. These patients with medicines, and you know the list of medicines that can cause extrapyramidal syndrome. There are other degenerative disorders that can cause Parkinsonian-like presentations. There are other infections that look like Parkinson's. Normal pressure hydrocephalus is a common differential when we discuss scans in our meetings. There are Parkinson's plus, that is what I was showing you, and large number of toxins. And you've seen the vascular Parkinsonism. Moving on, I was asked to say a few things about generally when do you start medicines after making the right diagnosis to the best extent you can. Well, it's important to take the patient into the decision-making process. And the points I have bullet pointed out here determine as to when is the right time to start treatment. Because unless there is a functional difficulty, we usually refrain from starting dopaminergic medications. Although the jury is out whether starting early or delayed starting makes any long-term difference. There is some concerns about starting levodopa and the complications it might cause. But again, these are discussions to be had with the patient. So shared decision-making with the patient is important. Now, there's a large number of drug classes that Shambo will be discussing soon. I've classified them into the MAO-B inhibitors and the amantadine, which have a modest effect only, usually well tolerated, and only in patients who have mild symptoms. Levodopa works, as you saw the apomorphine working for that patient, and it's the most effective. In fact, we have used the apomorphine challenge sometimes to confirm it's Parkinson's disease, although I must stress it's a clinical diagnosis. And then there are dopamine agonists, and I will enumerate the lists, but they come with their own share of complications as well. Now, this is a brief algorithm, which maybe you cannot see because the print is very fine. But the point is we observe the patient until the patient desires symptomatic drug therapy. And then we start the MAO-B inhibitors, if possible. If the response is inadequate, we move on to a dopamine agonist. Now, the monoamine oxidase inhibitors are mainly the selegiline, which we have used for a long time, rasagiline, which we have used as a once-daily preparation, and the more recent safinamide that we have used recently. And we have got to be more careful about the dietary interactions with tyramine-containing foods. Amantadine we use for dyskinesia all the time, but because of its low potency anti-Parkinsonian effect, I have tried a few patients very early to get some time. Now, the tremor-dominant disease requires anticholinergics, which comes with its own share of side effects. Triphenhexidil and benztropine I have used mainly in young people. Now, the non-ergot dopamine agonists are these three, including the transdermal rotigotine, which I find quite useful. The ergot ones caused fibrosis, heart, lungs, and so I have discontinued its use. Apomorphine, pumps and pens have been used for a long time, and now we have sublingual apomorphine from 2019 in India as well. Levodopa has been the workhorse, and among all the neurotransmitters, we have found levodopa to be the main chemical that has given patients relief for a very long time, combined with carbidopa or benserazide. We must remember that the CR tablet, which we give at night for nighttime symptoms, bioabsorbability is 70% only. So the dopaminergic therapies come with side effects of nausea, orthostatic hypotension, hallucinations and confusion, and the very important impulse control disorders, where patients have compulsive cleaning, and hypersexuality, gambling, and a lot of other problems from the dopaminergic receptor subtype stimulations. And we'll be covering that. Now, the main problems with levodopa are the motor fluctuations and dyskinesias, the wearing off problems, persisting tremors. What do we do? These are basic problems that come with complicated and longer duration of Parkinson's. Deep brain stimulation and LCIG, which is the levodopa-carbidopa intestinal therapy, is another therapy, but very expensive and not available. Now, there are other management issues like patients will have difficulty in swallowing as they go on. Patients taken into hospital because of fractures, and then the hospital orthopedic staff do not give the medicines at the right time. There are hallucinations, there are psychiatric complications, all of which make management difficult. I have not seen too many of the Parkinsonian hyperpyrexia syndrome, but it's a problem, what is used to be called malignant syndrome. Now, I put up this slide just because of the drug development is slagging behind in the conventional manner. We have lots of chemicals, and this was a paper I pulled up from the plant sources of herbs, which have been used for nearly 3,000 years in Ayurveda. And we must be exploring the plant side of things as well, like the Mayans and the Aztecics used to have lots of chemicals from where this dopamine was initially thought of and conceived. Now, there are non-pharmacological treatments that are equally important, including physical therapy, speech therapy, exercise, using sensory cues and visual cues. I just showed you that. The gate freezing, using laser pointers or walking over the stick. There are dance programs, there are aerobics, and a lot of other non-pharmacological treatment that is evidence-based. These are all evidence-based, and including voice training when one cannot hear. Role of diet. I have raised the melanoma because there's no guideline from L-DOPA and melanoma patients and melanoma screening, but malnourishment in Parkinson's disease, particularly advancement, bone disease, vitamin B12 for neuropathy are issues. There are alternative therapies that I'm also going to be talking about, including new drugs are not coming in the Parkinsonian field for a very long time. So we need to have a good idea about it. These are some key points, but let me move on in the interest of time. I think I'm 8 minutes over time now. So basically, I'd like to end by acknowledging the sources of my information and by thanking the Inovocare E-Academy for spreading knowledge across the board. And thank you very much. Sorry, I'm 8 minutes over time. Thank you.
Thank you, Dr. Ray. So I think we'll take up questions at the end of the session. And I request Dr. Shambo, my co-chairperson, Professor Santanu Tripathi, to call upon the next speaker.
Thank you, sir. I think the next speaker is Dr. Shambo. Dr. Shambo Samrat Samajdar, you are the next speaker, I suppose. So would you please come up and share your screen? By the time Dr. Shambo starts, let me say a couple of words about Dr. Shambo. Dr. Shambo is a trained clinical pharmacologist. He did his DM in clinical pharmacology from School of Tropical Medicine, Kolkata. Before that, he did his MD in pharmacology and MBBS from RG Medical College. Dr. Shambo is otherwise is a very busy clinical practitioner. Okay, primarily his area of interest, clinical practice interest, is in the area of allergic disorders, and I suppose diabetes and metabolic disorders primarily. But otherwise, he has a great passion for application of clinical pharmacology in practice and how clinical pharmacological expertise can optimize practice and patient benefit. This is his area of particular area of interest. So with these few words, we find Dr. Shambo as a very, very sincere, dedicated professional, and he has a long career ahead. I only wish him that he becomes a noted clinical pharmacologist in the country. I feel myself fortunate to mentor him. So over to Dr. Shambo.
No, sir. Thank you very much, sir. It is always, I always believe that no epithet is bigger to me rather than the feeling the studenthood, because I was experiencing studenthood of Professor Santanu Kumar Tripathi. So that is the biggest epithet that God has gifted me for my academic improvement. So with that, first of all, I just want to say very sorry to Professor Mrinal Kanti Roy sir, because today his marriage anniversary. I am from the core of my heart and total the Inovocare Healthsoft Solution team, I just want to say a very happy marriage anniversary to sir. Yesterday when I called sir told me that, but in the interest of academics, he also agreed to chair this session. So thank you very much, sir.
So we didn't know this. Professor Mrinal Kanti Roy, many happy returns of the day. Thank you very much. It was great to learn.
Thank you, sir. Thank you.
Okay.
Nothing is more than academy.
Yeah, that is the spirit of sir. So with that, I just want to share few thoughts of mine regarding this very important topic, that is newer therapy of Parkinson's disease. So the disclaimer is that I am not a neurologist. I shall discuss this topic from the, or rather dissect this topic from the end of a clinical pharmacologist. So this is the famous book when we came to know about Parkinson's disease, the shaking palsy. We can say in this book, Dr. James Parkinson had mentioned regarding the motor symptoms.
Dr. Shambo, you can change this slide or make it a full screen first and then change the slide.
I think, sir, I had made that.
Okay. All right, go ahead then.
Is it visible? Rohan, can you see?
No, it is not visible. You make it full screen.
There is some issue with your this thing. It is not coming in my screen also. It's not full screen.
Okay, sir, let me share again. So is it visible, sir?
It's visible, but make it full screen.
I had make it full screen.
Or else you can click on the slide, that also, because otherwise in my screen, the slide.
So Rohan, can you help me?
Slide is not changing.
Rohan, can you?
Yes, Dr. Shambo, if you can just select on the share screen menu. If you select share a single window, because I believe your presentation is already being, the full screen is already being done as per the last screen that you were sharing. Yes, now it's perfect.
Is it moving?
Now it has come full screen.
Is it moving? Slides are moving?
Yes. Moving.
Okay. Sorry for this technical glitch. So we'll dissect this topic from the end of a clinical pharmacologist. So as we are discussing the first description, or we can say the evidence-based description on Parkinson's disease made by Dr. James Parkinson, he had mentioned regarding the motor symptoms as well as the non-motor symptoms. So in the last line, you can see the senses and intellect being uninjured. So this is the thing we need to understand. And from 1817 to 1969, almost more than 150 years it took to get the first evidence-based drug, that is levodopa. So now we are in search of next generation drugs, but these slides, from these slides, I can see today we are also we are saddened by the sad demise of Professor Madan sir. So actually, this is a very core topic of physiology and pharmacology, from where we can understand the importance of dopaminergic symptoms of Parkinson's disease. So I am just focusing one, let me on the pointer. Yeah, so this is the GABAergic neuron we can see, which controls the thalamus. So if this GABAergic neuronal stimulation is more, so what happened? So there will be more inhibition to the thalamus. So ultimately the motor effect will be decreased. Now, what happens in Parkinson's disease? There is two pathways. This is the direct pathway and this is the indirect pathway. So in case of direct pathway, normally what happens? So dopamine will stimulate this D1, and for that, this negative neurons, that is GABAergic neuron, will be stimulated, and for that they ultimately inhibits this GABAergic neuron, so that our motion will be maintained. But in Parkinson's disease, in the corpus striatum, this pathway, this dopamine 1 D1 receptor stimulation will not occur, and for that this inhibition will be overt, and therefore this inhibition from pars reticularis to thalamus will be more pronounced, and that causes the motor symptoms, bradykinesia. Same things happens due to this negative stimulation pathway, or we can say the indirect pathway rather. Here this D2 stimulation will not occur. So if there is no D2 stimulation, so there will be ultimately feedback positive energy in this neuron, this glutamatergic neuron. So from subthalamic nucleus, they will stimulate the pars reticularis, and for that this GABAergic neuron will be stimulated. So whatever we discuss, the thing is that everything about dopamine, and with this focus on dopamine, whatever drugs we have till date and we are using, they are focused on this dopaminergic pathway, maybe direct pathway or indirect pathway. The thing is that starting from levodopa, then we get tolcapone or selegiline, everything is concentrating on that dopaminergic pathway. But whether restoring the dopaminergic tone in the striatum is everything, I think it can improve the motor function, but the delivery of dopamine to extrastriatal regions are the major concerns to produce different types of adverse effects. Apart from that, there will be variability in their absorption and transit across the blood-brain barrier. There will be non-physiological continuous release of dopamine, and this is why there will be much more cognitive problems, levodopa-induced dyskinesia, and we will discuss about that on-off fluctuations which happened 100% of the Parkinson's disease patients. The neuropsychiatric features will be there which significantly impact the quality of life, specifically the advanced Parkinson's disease patient. And this cognitive impairment and autonomic dysfunction associated with the Parkinson's disease is generally non-dopaminergic origin. So if we just concentrate on the dopaminergic system, that will not address these issues. So actually what is off? Off means the return of motor or non-motor symptoms despite having therapy. Apart from that, there is a chance of delayed onset of medicine action, and that is also known as delayed on. Dose can be completely ineffective, maybe due to some other reasons, and that is known as failed dose. Returning of symptoms before next dose, that is the wearing off. And in this beautiful diagram, and we know this is we can find it in Harrison. So the first picture, we can see the y-axis the clinical effect, and the x-axis the time after levodopa is introduced. So in the early Parkinsonism, we can see the levodopa action is much prolonged, and also there is a higher level of dyskinesia threshold. So the long duration of motor response as well as low incidence of dyskinesia when we initiate levodopa in early Parkinson's disease patient. But what happens in the moderate Parkinson's disease patient? The dyskinesia threshold is there, but the clinical effect threshold or response threshold is little bit higher up. So even if we are getting the levodopa response, but that is associated with side effects like dyskinesia. So on time will be there, but on time will be associated with dyskinesia. Apart from that, we can see the duration of action by levodopa is shortened. So here we can see that. And next, what happened in the advanced Parkinson's disease, there will be much short duration of motor response, as we can see here in this third diagram. Apart from that, the on time is consistently associated with dyskinesia, because that dyskinesia threshold is much lower. So this is why we need something extra than the dopaminergic system stimulation. So with that, as we talked about that indirect pathway image, if we just want to again remember, so there is dopamine, but there is also adenosine. It is just a play between accelerator and brake. So if there is more dopamine acts as an accelerator, so our motor function will be there, the car will move on. But adenosine acts as a brake here. So what happened in the Parkinson's disease, this balance becomes disrupted. So there will be less dopamine, but more adenosine in action. And that is why here we can see generally the adenosine is focused in that indirect pathway. And we can see these red lines, the adenosine receptor density increased. So there is more to consider in case of Parkinson's disease than dopamine, and there is the role of adenosine. And overactivity of this indirect pathway further impact the motor functionality. And as there is much more adenosine to a receptor, this cause the decrease in motor function. And for that we have one answer, and that is approved recently by US FDA, that is istradefylline. And here we can see the image, the PET imaging. This is the Parkinson's disease. This B group is Parkinson's disease patient as baseline. This is the control group. Now you can see as they are giving the istradefylline, it occupy the adenosine to a receptor, and the red line becomes diminished here. So in case of Parkinson's disease, this increased density of the red line, that denotes the higher concentration of adenosine A2A receptor, which is blocked by istradefylline. And that is why FDA approved istradefylline as an add-on drug to treat the off episodes in adults with Parkinson's disease in 2019. So another group of drug, that is COMT inhibitors, though it is also concentrated on that dopaminergic pathway, but this is opicapone, which is in April 2020 got the approval. And specifically the uniqueness of this molecule is the duration of action. In case of entacapone, we need to give it much more time. That is not a once daily dose, but here as its T-half is much longer, we can give it once daily administration. Apart from that, what is important, the cytotoxicity. It has the lowest risk of cytotoxicity. In case of tolcapone, we know the hepatotoxicity and it was banned. In case of entacapone, it is much lesser cytotoxic. And this picture, we know the water lily. Water lily was used by Mayas and ancient Egyptians for different types of neuronal disorders. And from that water lily, the concept of apomorphine arises, which is nothing but a mixture between morphine and sulfuric acid. But the uniqueness of this is that it does not have any effect on the opioid receptors. And we can see the progress of this molecule, this apomorphine. And from, we can see that 2003, it got the first time approval in USA, the injectable mode. And in 2019, the apomorphine launched in India. And very recently, US FDA approval done on apomorphine sublingual film. And what is important regarding this molecule apomorphine? It is not only a potent dopamine receptor agonist with broad spectrum of all D1 to D5 receptor, but also it has an antagonistic property on serotonergic receptors like 5-HT2A, 5-HT2B, and HT2C. Apart from that, it also blocks the alpha adrenergic A2A, A2B, and A2C receptor. It has some agonistic property to serotonin receptor. Why it is important, we will discuss in later. But before that, I just want to share one case that happened in USA. A 78-year male on apomorphine sublingual therapy started vomiting and attend emergency. So one injection given in emergency room by intravenous route, and that old man developed severe hypotension, admitted in critical care unit. So name the injection. I will wait for 5 seconds. If some answer arises, we will. I request Rohan to send one Cadbury to that person. So let's wait for 3 seconds. If any answer coming, what is the name of this particular injection?
Ondansetron.
Yeah. So Dr. Ankan will get definitely the not Ondansetron, but a Cadbury, definitely, from Mr. Rohan. So actually it was Ondansetron. So what is important, because concomitant use with 5-HT3 antagonist leads to hypotension, and that is why it is totally contraindicated, and we should be very careful if a patient of Parkinson's disease comes to our OPD or emergency, because though the apomorphine is not available that much in India, sublingual is not approved yet, but it will come into our market very soon, maybe 3 years, 5 years, like that. So that time we should be very cautious. So in USA, they use this trimethobenzamide as an antiemetic drugs when the patients were on apomorphine in their trial. But in India, we can use domperidone also. So injection apomorphine is available in India, and it is given in subcutaneous route. From 2019, it is available in India. The dyskinesia reduction happens with continuous subcutaneous apomorphine injection, and that can be used as a monotherapy also. What happened? 50% reduction of the daily off time, and that we can see along with the different trials conducted. So here we can see different types of studies which showed that daily time in off decreased almost by 50%. So this is very important and unique features of injection apomorphine subcutaneously. So what happens to non-motor symptoms? As we had already discussed that 5-HT2 receptors and effects of apomorphine on that. So it has an antipsychotic effect. So we all know the medication related atrocities that happen to different patients of Parkinson's disease. This apomorphine has a positive effect on visual hallucination. Another important thing is that there is lower incidence of emergent impulse control disorders. Specifically, why this? Because this ICD happens due to D3 stimulation, but compared to pramipexole and ropinirole, apomorphine has lower D3:D2 ratio. So apart from that, it also reduced the intraneural amyloid beta protein and also improved the short-term memory in mirroring models. There are benefits in terms of sleep dysfunction, neuropsychiatric symptoms, urinary dysfunction, mood and gastrointestinal symptoms. So this is an Indian experience with apomorphine. This was published in Indian journal. So we can see there are some good effect, good clinical response in Parkinson's disease patients with apomorphine. And there are some patients who had experienced some local reactions also with apomorphine injections and apomorphine pump. This is the PI. So I am going to another molecule known as pimavanserin. So it is approved by FDA in 2016. Why it is important? This is a first-in-class atypical antipsychotic that does not induce clinically significant antagonism to dopaminergic, adrenergic, histaminergic, or muscarinic receptors. So this is why it was first time the FDA approved this drug for treatment of hallucination and delusions in Parkinson's disease associated psychosis. And this drug, pimavanserin, is not yet present in India, but in India we have safinamide and droxidopa, newly approved drugs for Parkinson's disease by 2019. So safinamide is orally active, selective, reversible MAO-B inhibitor. It acts both dopaminergic and non-dopaminergic property. So glutamatergic property it has, and it is used generally in case of mid to late stage fluctuating Parkinson's disease as add-on therapy. What is its uniqueness? It increases the daily on time without dyskinesia. But yes, there are some concerns with dyskinesia with this type of molecule. Droxidopa is not directly for the management of Parkinson's disease, but we already discussed the autonomic dysfunction that happened with Parkinson's disease. So droxidopa used for symptomatic neurogenic orthostatic hypotension, and this is due to postganglionic noradrenergic impairment that happens in Parkinson's disease. So actually it is a prodrug of norepinephrine, so it is used. But what is important, the labeled indication also mentioned this is a prescription of neurologist only drug. These are not available in India, but upcoming drugs, duopa and levodopa inhalational powder. So these can bypass the stomach, the hepatic metabolism. So this is the uniqueness, and this can be used as a on-demand basis also, this inhaler. So we hope that by again 5 to 10 years we will get this molecule. Another important drug, that is tavapadon. Whatever drug we talked about till time, they are more focused on D2, D3. But this is the first time we have some drug which is more focused towards the D1. Apart from that, as it is a partial dopamine agonist, the side effects are much less, specifically that dyskinesia. So this drug could be helpful specifically in case of later stage of Parkinson's disease. And now coming to the last part of my presentation, where we don't know much till date. The drugs are now in the development phase, but it is very important to understand the pathology. Already Professor Ray had mentioned beautifully the pathology behind Parkinson's disease, but I want to focus on one molecule again and again, that is alpha-synuclein, and related other issues like increased mitochondrial dysfunction, oxidative stress, and apoptosis. So to target that, if we have something more, so here in this picture we can clearly see how the alpha-synuclein synthesis happen, and after that there will be a aggregation, and this aggregation, they acts like a prion-like disease model. So they infect one cell to another cell. So this aggregation product will go to another cell and the neurodegeneration will continue. So we need to have something to stop this process, and for that these are the agents which can stop alpha-synuclein synthesis. Then when it becomes aggregated, there is a chance to directly causing the mitochondrial dysfunction, and to stop that we have GLP-1 analog. Apart from terazosin, ursodeoxycholic acid, inosine, N-acetylcysteine, and glutathione. Apart from that, there is a system which can clear it by the lysosome. That lysosome autophagy system, if we can stimulate that, that also can help us. We have some drugs like linotinib to increase this process. So the thing is that this is another important place, the immunotherapy, the vaccines, they are also in making in phase 1, phase 2 clinical trials to stop this prion-like disease transmission. we are in search of different types of vaccine. So we can see this whole galaxy of drugs. They are in different phases of clinical trial. But one thing I just want to mention, there are symptomatic therapies. We can see the lower portion, the symptomatic therapy. So many drugs are there. But in the disease modifying therapy, there are much less drugs that is available. Yes, the GLP-1 analogs, though they are primarily anti-diabetic agent, but we can see the effect of GLP-1 analog in this disease pathology. And apart from that, if we also go by the disease of Alzheimer's disease, like another important and most common neurodegenerative disease, there is also a role of GLP-1 analog. And also we called Alzheimer's disease as type 3 diabetes, we all know. So there is a very important role of that type of molecules in Parkinson's disease. Also, we need to see the phase 2 and phase 3 clinical trials. So in nutshell, these are the drugs which are in pipeline. As we had already discussed, I am not going in details, but these are, I think there are lots of future young doctors today present in our delegate link. So I hope this, when you will practice these, many of from this chart will be available to treat your patient. So we can see in phase 1 clinical trial, 41% of those drugs are now in the phase 1 clinical trial, 53% are in phase 2 clinical trial, and only 6% in phase 3 clinical trials. And apart from that, though the small molecules consist the larger proportion of those on upcoming drugs, but there are some monoclonal antibody or vaccines developing. That is, almost 5 trials are ongoing with different types of monoclonal antibody and vaccines, which can prevent that neurodegenerative process, that progression of that neurodegenerative process. And also Professor Ray had given the emphasis on those herbal extract. There are 2 trials ongoing on those herbal extracts. So due to the paucity of time and other issues, we are not discuss that devices and different interventional procedures today. I just want to thank all of you for your patient hearing. And I want to thank this small fish, which is also known as zebrafish. The lots of zebrafish has been sacrificed due to for the research in the field of Parkinson's disease. So this is a very important fish we must appreciate, this zebrafish. So thanking zebrafish, I want to conclude my presentation. Thank you all.
Thank you very much, Dr. Samajdar, for the wonderful presentation within a very short time given to you. You have been able to give us a huge information and very otherwise a good summary of the newer or the advances in the drug therapy of Parkinsonism. In fact, it is also to a great extent futuristic too. I am sure that this is going to be very useful to our young postgraduates and also people like us. Thank you again.
Thank you.
May I now again come back to Mrinal Kanti to go to the next session, please.
Thank you, sir. Thank you. Thank you. Thank you, Professor Santanu Tripathi. Now, our last speaker will be Dr. Ankan Pathak. Now, a few words about Ankan. Ankan, when joined in MD, the first year student. So I had some interactions with him and I took some classes with Ankan. I know that he is a promising boy. And at that point of time, I told his father is very close to me. You all know this H.S. Pathak, who is now the chairman of API. I told him that your son will shine like anything. One day a day will come when Ankan will be carrying the torch for the next generation. And he is a wonderful boy. And he did his MD and he passed out MD last year in a brilliant result. Presently, he is working as a senior registrar in JNM Hospital. Now it's a medical college in Kolani. With these few words of introductions, without wasting much time, I will request Dr. Ankan Pathak to directly go to his topic. That is the challenges which we face in relation to the adherence of the therapy, As we all know, adherence in Parkinson's disease, we have a lot of challenges.
Thank you,
Ankan,
sir.
please start.
Yes, sir. Thank you, sir, for the kind words. It is indeed a huge Herculean task for me to speak after such legendary figures, but I'll try and do justice to my talk and to my topic. So I will skip whatever has been said in the previous talks because of paucity of time, but I'll try to keep it short, brief, and to the point. We all know that Parkinson's is the second most common neurodegenerative disorder after Alzheimer's disease. And as internists, as clinicians, we are bound to face such patients in the long term because of the increasing geriatric population. And it is very important, that we understand that Parkinson's from head to toe, from top to bottom, is actually a chronic, progressive, complex disorder. If we talk about the clinical features, its diagnosis, its pathogenesis, it is complicated. And even when we talk of treatment, as Professor Partha and Dr. Shambo said, that the nitty-gritties about when to start, when to actually increase the dose, when to actually wait and watch, it makes all this, Parkinson's a really tricky disease to deal with. Now, if I have to sum up what was said in the past two talks, in one single sentence, if I have to say what pathogenesis is actually the hallmark of Parkinson's, it is basically a degeneration of the dopaminergic neurons in the substantia nigra pars compacta, which leads to reduced striatal dopamine levels. There is intraneuronal proteinaceous inclusion bodies, which is basically known as Lewy bodies, and that primarily contain the protein called alpha-synuclein, and hence Parkinson's is actually a type of synucleinopathy. So when we talk of adherence, when we talk of compliance, we need to understand that the main challenges that Parkinson brings about is the long-term therapy, the cost of medications, the medication responses. Sometimes drugs like levodopa itself is tricky and can actually increase the amount of side effects initially, which actually makes it worse for the patient. And also because of the associated dementic patients, which is very common in patients of Parkinson's, this forgetfulness is actually a very common feature. So treatment compliance or adherence is a critical issue in clinical trials as well as in clinical when we see patients clinically. Non-adherence by patients with chronic conditions is basically linked to financial issues, to increased patient and society burden, and also since Parkinson's itself brings with it a reduced quality of life in general. One study which was actually done in the US found that in patients of Parkinson's, suboptimal adherence was really common and varied to the tune as much as in between 10 to 67%. Now, if we have to define what the World Health Organization actually meant by what adherence is, it is basically the extent to which a person's behavior is in taking medications, and it corresponds with agreed recommendations from a healthcare provider. When we talk of the dimensions of adherence, which is a multidimensional phenomena, it actually encompasses the social and the economic factors. It also includes a provider-patient healthcare system factor. There is related condition factors, there is therapy-related factors, and last but not the least, and probably the most important amongst all, is the patient-related factors. So because we don't have any clinical or biochemical measurements, we don't have subjective measurements or objective measurements, which are actually the gold standard, we actually have to approach it differently when we talk of medication adherence in any disease, specifically in Parkinson's is concerned. By subjective measurement, what we have to do is we have to obtain a proper history taking by families, family members, caregivers, and also by the patient about the use of medication by the patient himself. Objective measurements by recounting the counting pills, seeing the strips, examining the pharmacy refill records, which are again not much robust in our part of the world, and also by biochemical measurements, which are obtained by adding a non-toxic marker to a medication and detecting its presence in blood or urine, or measurement of serum drug levels, which are difficult, but studies are undergoing. So currently, what we find as a gold standard in measuring adherence to a medication in patients of Parkinson's, the combination of all these three measures can be used to assess adherence behavior. Now, at the root of my talk, we need to understand why does adherence occur. We keep talking about the patients are non-adherent. We keep talking about patients being non-compliant, but we do need to understand why does adherence or non-adherence actually work at the patient level. And actually, from what we understand is the main reasons actually range variedly. It actually ranges from as much as work issues to family issues to specific health reasons, and we need to ask these patients and actually target that specific mechanism as to why non-adherence is actually working. For example, if I have to actually give an example, a patient may begin to feel sicker and attribute it to the change of the medication itself, causing them to take a day two off and stop medication entirely. And as we know, in diseases like Parkinson's, in diseases like diabetes, this can actually worsen the patient in the longer run. Now, again, we need to understand that symptoms of Parkinson's do fluctuate from day to day, even from time to time, and therefore such things cannot always be recorded reliably during our clinical evaluations of these patients. Now, there are issues with medication use itself, and the reason why I touch upon this topic again is because when we actually prescribe drugs like levodopa to such patients, we need to actually make them understand that this is part and parcel of what you're having. This will stay with you for the longer run, and simple tweaking of the dose or addition of certain other drugs which will actually help ameliorate certain symptoms that you might have with these drugs. Now, we all know that levodopa is the gold standard anti-Parkinsonian drug, and any new drug or any new therapy which actually comes into the market needs to be compared with levodopa before it is actually approved for medication, as in case of Parkinson's is concerned. Now, there is certain things like levodopa-induced motor complications, which actually consists of fluctuations of motor response, wherein Dr. Shambo actually really beautifully illustrated the on and off phenomena that we actually come across day-to-day life. Now, there are certain things that I would like to add in with levodopa. We know that behavioral complications are common with Parkinson's and actually can also be encountered in patients who are undergoing treatment with levodopa. There is a very common or a very rare syndrome, but we studied in our textbooks, called the dopamine dysregulation syndrome, where it has been described where patients actually have a craving for levodopa and they actually take frequent unnecessary dosage of levodopa, leading to worsening of symptoms and also developing purposeless stereotyped movement disorders and behaviors, and also sorting of objects, which are commonly known as punding. Levodopa can also enhance postural hypotension in the elderly, which again gives rise to a phenomena called recurrent falls in the elderly, which actually is an independent marker of morbidity and mortality in the geriatric or the elderly group or age group. Now, what solutions do we have for treating non-adherence to such drugs? The number one option that we have is obviously to make patients understand that this is part and parcel. But apart from that, it's time that we take the help of technology solutions for treatment for non-adherence. And here comes the concept of smart pill packs, where pills are removed from the pack. Data such as type of pill, position in the pill pack, and data and time of removal are recorded. If the pills are not removed according to the assigned treatment plans, reminders can be generated to alert the patient and the physician who had actually prescribed the drugs. Similarly, the study teams will be alerted if there is too many doses which are removed within a given time window, allowing them to reach out to patients when it is necessary and take steps. While this is obviously a useful step forward, these pill packs will not be able to track if the pill was actually taken by the patient after its removal for the pack. So if I have to tell about it pros and cons, yes, we can really track whether the pill was actually taken by the patient. but whether it was consumed by the patient remains one disadvantage that a smart pill pack cannot help us in this manner. There are certain things called wearables, where in Parkinson's disease specifically, developers of the Apple Watch are building capabilities to detect changes in tremors associated with the disease. While this obviously will not be able to confirm the dosing schedule, what it will do is that it will be useful in the future in pinpointing improvements to symptomatology resulting from therapy or decrease of increase of symptoms when the patient actually stops taking drugs. We move on to smart device applications. In this era of new technology, applications are now being used in clinical trials with proven utility and accuracy to confirm dosing adherence remotely. What patients do is they use such applications on their own smart devices, which are provided by sponsors or facilitators. And through this application, the patients are reminded at each time to take their medications and also given a particular specific guidance on how to properly take it. Furthermore, what we can actually do is to take the video recording of when the patient actually takes the drug and the correct pill is being taken and is successfully ingested by the patient. So what was a disadvantage as far as smart pill therapy is concerned is actually helped by smart device applications, where we can actually see by way of video recording capabilities whether the patient is actually taking the drug himself or not. Now, why do actually non-adherence work as far as Parkinson's disease is concerned? We actually understand that specifically it is the lack of sleep or fatigue, or mood and cognition disorder associated with certain perceptual problems, hallucinations, and memory disorders are actually correlated with lower levels of adherence, which is understandable. Sleep attacks associated with anhedonia, which is a low mood for a chronic period of time, associated with chronic forgetfulness, actually is a stronger predictor of lower adherence to Parkinson's disease medication. Fatigue is obviously one of the most common and disabling symptoms in every stage of Parkinson's disease, and also reduces your quality of life, and as a result does impact to some degree as far as level of adherence is concerned. Based on the results of one study which was conducted in the United States, it was found that excessive daytime sleepiness was an important predictor of non-adherence in Parkinson's disease. And depression is also a common symptom associated with Parkinson's. And both of these, when combined together, actually led to worsen compliance in this group of patients. Now, when we talk of endpoints or therapeutic goals in Parkinson's disease, it basically is of three main heads. Number one is to control your motor symptoms. Number two, to prevent your motor complications, take care of the non-motor complications, and also to actually prolong the life of a patient, associated with, more importantly, better quality of life. Now, we all know that in advanced stages of Parkinson's disease, there is a huge degree of motor and non-motor complications of disease. And it is here that there are multiple prescriptions or multiple drugs which are actually given to these group of patients. And when we actually prescribe multiple group of drugs in these patients, we understand that Parkinson's as a group of Parkinson's may be associated with multiple comorbidities. We have diseases like diabetes, hypertension, osteoporosis in certain groups of patients. And as a result, they need to take multiple groups of drugs for their benefit. And this is where the concept of polypill and polypharmacy comes into polypill and polypharmacy concept came into being, where polypill and polypharmacy was associated with a decreased level of adherence in such patients. And this is the concept where fixed dose combination actually works to decrease the number of drugs that a patient takes, and as a result, increase the level of adherence in such group of patients. Now, as Professor Partha has said, this is one issue that we very commonly face. A patient of Parkinson's admitted to orthopedic or a surgical department with whatever issues, and this is where the problem begins, where because of the complexity of the regimen of Parkinson's disease, these patients are actually not administered these drugs before a surgical procedure takes place, leading to adverse clinical sequelae. One of the first studies about this problem came from a retrospective study of patients with Parkinson's disease who were hospitalized in the United Kingdom. And it was in that report an alarming percentage of patients admitted to the hospital had critical medications stopped or omitted. And even more worryingly, of these, 60% experienced significant adverse effects, including the need to transfer a patient to the intensive care unit. So what we actually take away from this study is that it is important that we educate the patient, we educate the caregiver, we educate the family members that in case of any stress event, in case of any impending surgical intervention, whatever be the situation, the drug need not be stopped, should be continued until and unless a medical specialist actually sees to the patient. Such patients do develop psychosis, and this is one thing that is actually very important to manage, because Parkinson's associated with dementia commonly do experience spontaneous visual hallucinations associated with delusions and paranoia, and also in the absence of medications for the motor dysfunction. All this together actually make it a really difficult condition to deal with. However, whenever we deal with a case of psychosis with Parkinson's, we need to rule out correctable causes, and that remains treatment of metabolic conditions, treatment of correct whatever underlying sepsis or infectious condition that you have, treat the toxic metabolic causes if you have, and something that is very, very not seen to in day-to-day clinical practice is see to it that the patient does not have bladder and bowel dysfunction, because such patients do develop delirium and psychosis very commonly. If the symptoms do persist even after ruling out such conditions, the anti-Parkinsonian drugs should be slowly reduced, which usually results in a worsening of the Parkinsonian features that may be poorly tolerated. And if all of these above measures do fail, treatment with antipsychotic drugs might be needed, probably with quetiapine, which is again an atypical antipsychotic, which is again recommended by the American Academy of Neurology and is usually reported as a most frequent drug to be used in treatment of psychosis with Parkinson's. Delirium or acute confusional state remains another issue in treatment of Parkinson's, and that too more in inpatients rather than outpatients. And again, as with psychosis, it is important that we rule out infectious causes, we rule out toxic and metabolic etiologies before considering antipsychotic treatment. The reason why we are dealing with this because a single episode of psychosis, a single episode of nausea, vomiting, a single episode of stoppage of drug in an orthopedic or a surgical ward can actually adversely affect the patient, and in the longer run can actually lead to non-adherence as well. Nausea and vomiting, we all know, is a part and parcel of levodopa and dopamine agonist, and need treatment with metoclopramide and other centrally acting antiemetics, because, and we need to be very careful because these are contraindicated in Parkinsonian patients. As I've already mentioned, that neurogenic orthostatic hypotension remains a very common cause of levodopa therapy, as well as autonomic dysfunction itself. We need to understand that there are drugs, yes, drugs like midodrine and fludrocortisol, but these drugs again might lead to supine hypertension and hypertension as well. And hence it is important that we tweak the drugs or dosage of levodopa as and when necessary. And another thing that is important in orthostatic hypotension is that we need to take into account that orthostatic hypotension can also be present because of dehydration, can also be present because of antihypertensive drug, particularly your thiazide group of drugs, because these actually propensate the ability to cause dehydration. And it is important that we rule out such causes before treating these patients with fludrocortisone and midodrine. Now, what are the practical recommendations to improve adherence to pharmacotherapy in patients with Parkinson's disease? For good cooperation with our patient, as I've already mentioned, a solid communication is the backbone of what we've been talking about. We need to express some degree of concern with the patient about his disease and also satisfactorily educate the disease itself, the course of the disease, the necessity of treatment, and the potential complications that might arise from this disease. And all these are very important in the long run for you to maintain adherence with such patients. Various dosing devices like reminders and alarms, which are set on phone calls or cell phones or wristwatches, are advisable tools for improving adherence. And you need to actually empower the caregivers to actually maintain drugs on time for better outcome in the longer run. Adherence may also be improved with easier dosing regimen, and what could be achieved with controlled release dopamine receptor agonists like ropinirole and pramipexole, or also by using transdermal patches with the help of rotigotine. And another option is referring patients to specialized movement disorder centers so that they can be given the advantage of a continuous subcutaneous apomorphine pump, a levodopa carbidopa intestinal infusion that Sir was talking about, or a possibility of deep brain stimulation. Now, as much as pharmacological treatment is important, we need to understand that non-pharmacological treatment actually comprises a huge cornerstone of therapy. We have gait dysfunction, we have speech impairment, we have exercise, and we have caregiver fatigue and caregiver burnout. Amongst them, one of the most important features is a caregiver fatigue and a caregiver burnout. And it is here that you need to know that whenever a caregiver suffers from certain degrees of fatigue or burnout because of chronic involvement with such patients, these patients need to be admitted for a day or two to any home care facility, to a hospital for that period of time, to allow the caregiver some amount of time to actually recover from what, and we understand that this caregiver must be going through some amount of complications as far as mental and physical health is concerned as well. Gait dysfunction with falling is an important source of disability in Parkinson's disease and also leads to recurrent falls in such patients. Dopaminergic treatment or therapy can help patients whose gait worsen during the off time, but we need to know that during the other phase, there is currently no specific therapy for gait dysfunction in Parkinsonian patients. Exercise remains a very, very important part of therapy as far as Parkinson's is concerned. As much as we've seen and studies have seen that patients who actually go for passive exercises with full range of motion actually do better in the longer run as far as quality of life is concerned. One thing that is mentioned in the Harrison's textbook of medicine is the Tai Chi dance or form of physiotherapy or yoga, which is important, but as how far that is clinically feasible in such patients is not known. To sum up my talk, we need to understand that medication adherence is not solely the fault of the patient. It can be attributed to the drugs as well. It can be attributed to the very fact that multiple patients or most of these patients are elderly, have some degree of dementia, have some degree of forgetfulness, and with associated poor quality of life, it is difficult to maintain adherence to these patients. We can talk about all the recent developments, the recent pathophysiological mechanisms of Parkinson's, but if we do not address the very concept of non-adherence, all these studies, all these drugs will not help as much as it will not help if we do not understand what non-adherence brings to the table as far as Parkinson's is concerned. I hope I did justice to my talk. So thank you, teachers, for giving me the opportunity to speak in front of such an august gathering. Thank you.
Thank you, Ankan. I think the three speakers have done their marvelous job, and they have taken us through a journey of Parkinson since 1817 to 2021. And a lot of things we have learned today, we have been enriched. I think we can have a brief discussion. If there is any question in the chat box, or if somebody has got any query, they can make it. Otherwise, we will make some comments from Dr. Tripathi and myself. We will make the comments. And if there is any questions from the floor, I think the speakers are ready to answer their questions.
Yes, I'm ready for questions.
Yeah, all the great speakers, they have done marvelous job. And it is a little enigma that it is Parkinsonism. I think, in fact, when I was starting my career in medicine, that was way back in 1972. And that time it was pre-medical. And then after 1 year, we actually joined the first year of medicine. And that was also the time when Materia Medica in true sense was transforming to the modern pharmacology, because around that time, early 70s, that the better understanding of receptors and receptor-based drug therapy, that actually started becoming popular and was integrated into the medical curriculum. So I remember we were almost on the threshold of studying the old-fashioned pharmacology to the new fashioned. In fact, the first time we had a book, local Indian book called Satoskar's Pharmacology, where we, for the first time, we found this beautiful explanation of this. This was also why we sometimes became, when we became pharmacology teachers, I sometimes wondered that why in undergraduate pharmacology, we give so much of emphasis to Parkinsonism, management of Parkinsonism. How many of the general practitioners are expected to actually treat Parkinsonism? But then we felt that this is possibly one of the model where you can showcase the drug therapy. Okay, so you can predict, you can explain. But then what we thought during our early days of pharmacology learning in undergraduate, very soon we realized it's not that simple disease. Okay, it's so complex. Now we even today, the mystery of Parkinsonism possibly has not been unveiled totally. Okay, there is a long way to go. Particularly the last speaker, I must say, has done a wonderful job, Dr. Ankan. When you talk of adherence, here is a disease where there is a dramatic improvement in the symptom. At least when you start the treatment, levodopa is still today is wonderful at the initial correction of the symptoms or relief. And the patient definitely would be experiencing that. Despite that, how is it that there is also an adherence issue? So it is beyond just the disease or the wonderful drugs that are available for treating the disease. There are so many other complex factors, the behavior, patient behavior, all these will come into play. Over and above that, I must say that Parkinson's is becoming, because it is otherwise an age-related disorder. So it is also the elderly age where we find there are so many other different kinds of degenerative and age-related disorders an elderly person is likely to suffer from. So if the same person suffering from Parkinsonism or also have multiple other comorbidities, how that can also impact on the adherence, that is also another issue to also consider. I hope that we can have certain kind of discussion. Other than that, also I was just thinking that rehabilitation in Parkinson's disease, okay, when you talk of rehabilitation, I mean professional rehabilitation, say for during our surgeon, Professor Ghosh, okay, and he had Parkinson's disease, but then we found that he was very regular in his surgical practice also. I would also request Professor Ray or Professor Partha or Professor Mrinal Kanti to say a couple of words about the fine skills. Okay, so doing surgery, holding a scalpel, doing surgery, okay, how that is affected and how that kind of professional activities, okay, remaining engaged with that kind of professional activity will otherwise delay the progression of the disease. Okay, of course, that has nothing to do with treatment adherence, but then Dr. Ankan has rightly pointed out that to remain engaged in activities, exercise, okay, dance even, okay, so that also helps It is not just drugs. So let us start a little bit of discussion on these issues. Over. Thank you.
Partha, do you like to make any comment on that? The finer talks.
Yeah. No, but you are the senior most neurologist of whole of Eastern India. You go
Definitely,
first.
I will comment. I will have my comment reserved, but
Okay.
just as a, yes, he's asking.
Yeah.
That's why I'm telling.
Okay.
I will
Yeah.
definitely comment.
Yeah, definitely. So first thing, in answer to Professor Tripathi's question about the initial good response, this is described as honeymoon period. When you first start off with it, there is definitely a very great improvement in functionality. Your question was then, if people are getting good effect, why are they not continuing with it? Now that happens because of the adherence issues that were so well enumerated by Ankan Pathak today, for all the various different reasons. As the disease progresses, there will be the effect of Parkinson's disease dementia coming in. There'll be the effect of polypill burden in usually a senior citizen coming in. There is so many other factors that will start to influence. Plus, basically the effect of the drugs after the initial honeymoon is not that dramatic. So the patients are less encouraged. There's a compliance issue that creeps in at that stage. So I think it's the human behavior. And of course, the human attitude of forgetting to take something. We have discussed it in early meetings. Diabetics do it, hypertensives do it to their peril. And Parkinson's disease safety net is that if they don't take the levodopa, they're likely to get worse. And so they will take it. It's worse in case of diabetes and hypertension because it's a silent killer. Blood sugar, hypertension going up, you never know. That's the first question. Now, secondly, without naming any senior surgical personnel, I think having Parkinson's disease definitely puts an impediment on your fine motor skills. That goes without saying. Now, it all depends upon what is the functional status of that particular individual. And I think definitely an occupational health assessment needs to be done for that person if he doesn't have the insight into his surgical skills. There is no way a Parkinson's who has lost 50% of the dopaminergic neurons in his basal ganglia, in his dominant hand, or even in the non-dominant hand where he's using the retractor, can work as effectively. Certainly not, I will not have a brain surgery done or any surgery, it's a question of patient, care, optimum patient care. That surgeon can train, teach, mentor, and do even robotic surgery with an assistant. We are not asking that person with his great experience not to do the actual work, but there will be definitely an impact on his fine motor skills. And no amount of therapy, no amount of other rehabilitative methods will be able to go around that problem. So I think every surgeon should have self-reflection to avoid that. And if he doesn't have self-reflection, because he may well be dementing, you see, in which case his assistant or his colleague should take him for a more senior role, which is non-clinical. Even physicians like me, if I have Parkinson's, I should be having annual assessments by Professor Mrinal to assess my cognition, to make sure that I am making the right judgments for my patient. There is no way a doctor who is not well enough to treat a patient should be allowed to treat, because it's risky for that doctor to go into that risky arena, because somebody will then fault him for something that was duty of the medical profession to remedy and look after, because anybody can fall ill at any point. We are all doing highly charged jobs, and that applies for our younger friends here as well. Your third question was, I think, to do with the dance therapy and how can things improve. Now, neuroplasticity can somewhat, if we do diffusion tract imaging, DTI imaging, and neuroplastic studies, there is some evidence that reorganizing the motor circuits and using the connectome principles, the brain is very much like an internode and node, and every part of the brain is talking to each other. The lobar hypothesis that we've been brought upon from 19th century neurologists is gradually being shown the door. That was the anatomical model. Now the functional model, every part of the brain is talking to every other part of the brain, and both hemispheres simultaneously, real time. And that's been proven not by hypothesis, but by actual real-time studies on DTI and fMRI bold. You can see, and when I talk, certain parts of my brain light up, which Ankan or Shambo's will not. So everyone is different depending upon the training. So yes, there is a role of all these things that will build up deficits, but it cannot overcome. And naturally, you cannot be an airline pilot riding the Rafale if you have got Parkinson's. No way, because it's far too risky for that plane and your life, pilot's life, and wherever it lands. I'm just talking about the optimization. The third thing you spoke about was about the dances and complementary therapy. I have actually circulated my my slide set on the thing. Please, everybody have it. It's recoverable from the chat box. Ankan did that. So I'm sure why some like Partha Biswas is not able to do it, but it's available. Because all the rehabilitation therapy, non-pharmacological approach, and I'm also a member of the Indian Federation of Neurological Rehabilitation, for Parkinson's patients, occupational therapy. And this was my previous mentor here in Birmingham. Carl Clark used to do a full occupation. He was a professor of neurology, and he did studies on occupational therapy and Parkinson's and the benefits. This was not in the NICE guidelines, National Institute of Clinical Excellence guidelines. Before, I think 2000, he published it. So this is a 21-year-old data about occupational therapy, physiotherapy, music therapy. I actually collaborate with the Canadian Michael Thorpe, who does metronomes and makes people walk. And you saw some videos, which I showed at the beginning, of people stepping over a laser pointer. And that's very effective. You're using sensory cues and even auditory cues with the clicks to walk over obstacles. And you saw the freezing of gait at the very beginning of the videos. The patients had the ignition failure at the very beginning. Once you set up the cadence, then the person starts to go. And then when they approach a narrow door, they freeze because of the visuospatial problems that go with it. So there's a huge amount of non-pharmacological treatment waiting to be done, which is untapped, because like exercise, no big pharma is spending money on exercise. And you and me and everybody will get our hypertension, diabetes better if we exercise 30 minutes a day, 5 times a week. That's a WHO guideline for the last 25 years. I have read, but never done. Likewise, this dance therapy and the occupational physio speech therapy for hypophonia and mumbling. If you do elocution, and speech therapists are qualified. I'm talking about India. All that I'm saying data is from India. That was I put my disclaimer up that I don't have any, all the data I'm saying is applicable for the Indian setup. And I network all over India through Zoom. So all these therapies on rehabilitation, plus the pharmacological therapy, plus I am attending a veterinary course for the last 21 days. They're far ahead in pharmacology in the veterinary field.
Thank you, Partha. Thank you. Thank you.
So there's lots to talk about. Thank you, sir. I'll let you take over now.
Thank you very much for elucidating the subject. So what is my comment? I have got 2 or 3 important comments. The speakers have touched the very relevant points in the 3 topics. This is number 1. Number 2, physicians who are attending today in this particular seminar, and also the pharmacologists who are attending, nobody can escape from treating a Parkinson's disease because the burden has increased because of the aging process. Now, all over the world, in the 2004, the total burden was 5 million, but it is expected that it will be double, almost 9.5 million by 2030. So someday or other you will come across, or someone of your relatives may be a victim of Parkinson's disease, and you will have to face this particular problem. But what I tell you, that all that shakes is not Parkinson. That is a very dictum. All that glitters is not gold. All that shakes is not Parkinson. So mind you, whenever you diagnose a case of Parkinsonism, you should be doubly sure that really I am doing a case of Parkinsonism or Parkinson's disease. So Parkinson's disease is one, IPD, idiopathic Parkinson disease, and Parkinsonism is a host of disease which actually mimic like presenting Parkinsonian features initially, but later on end up with other things which Partha has tried at the very beginning to show you. And that's why a lot of research has been taken place. Initially, it is very much misleading. Another 2 or 3 important points I like to highlight. Whenever I come across, I have a number of Parkinson patients right at this moment in my personal care. Even some of my relatives are also suffering. Some of my renowned teachers, which Professor Tripathi actually asked, he was a renowned surgeon. He had these levodopa doses frequently. Last time also when I met him, he is no more now. See, last time when I met him also, he told me I increased my levodopa dose when I go to the operation theater. But mind you, only one thing I tell the students, that the Parkinsonian tremor is a rest tremor. It is not an intention tremor. So if you were to choose between the intention and the rest tremor, God, let me give me the rest tremor, not the intention tremor. But with the intention tremor, you cannot take a glass of water in your mouth because you will try to, everything will spill out. But with a rest tremor, whenever you are taking something in your hand, it will immediately stop. Again, after some time, when it will be in a resting position, it will come back. So this is a clinical point. So when you take the knife at your hand, immediately the tremor will stop. So initial part of Parkinson's disease, there is no problem. The patient can perform some of the operative procedures. But as the disease goes on and on, as there is a neuronal degeneration, dopaminergic loss and loss, because this is a natural history of the disease, nothing at our hand to stop the progression of the disease. So a time will come, automatically it will go from here and whole classification, grade 1, grade 2, grade 3, grade 4, like that. And a time will come, the patient will become a wheelchair bound. So initially there will not be any problem. And also for first few years, the level which the Shambo has tried to show, the graph, the y-axis and x-axis, where the gap between this threshold level of dopamine response and the initiation and development of the fluctuations and dyskinesias in relation to the duration of the therapy, in relation to the disease process, gradually decreases, and all the complications starts early, even if after crossing the holidays of Parkinsonian holidays. Good. So second point, whenever you diagnose a case of Parkinsonism, first day you tell the patient and the patient party, write in their prescription that this is the natural course of the disease. There is nothing to stop or halt the drug. I can only delay the whole process. There was a term, start slow, go slow, and start low. That means small dose, and later you start, later fluctuation may come. But the controversy has started now, whether at the cost of your functional, involvement, whether you will start Syndopa early or not. But there is a controversy, I'm not going to that point. Somebody preferred to start it early, somebody preferred to start it early. So every patient is an individualized patient. Every patient is an individual. Two things I tell you. See the patient first. When the patient enters to your room, whether it is asymmetric or not. If it is bilaterally symmetrical, it is not a Parkinson's disease. To start with, no Parkinson's disease is bilateral. Dictum for the students, I'm telling to the students. For the dictum, it should be asymmetrical, asymmetrical, and asymmetrical. There should not be gross dementia initially. If there is any find that in cognitive scale patient is scoring less and less, in the beginning, if there is dementia, it is not a Parkinson's disease. Development of dementia within 1 year of Parkinson's disease, it is a dementia with Parkinsonian feature, Lewy body disease may be there. So you should be very careful. Dementia should not be there. Response to levodopa therapy, it should be marvelous and miraculous with the single dose of levodopa therapy, like your apomorphine. If you get the response, most likely the patient has got Parkinsonian disease. So these are the few points clinically pointer to Parkinson stamping at the very beginning. And after that, the escalation of dose and other things, all these things have been discussed very nicely. One question has come in the chat box regarding the midodrine. I'm supposed to ask this to Ankan, but I am answering it. Midodrine is quite available in India. Now you can get it in a 5 milligram tablet. It is in the refractory cases of the orthostatic hypotension. We generally go for it. But mind you, the supine hypertension is one of the important complications because we all know this is an alpha agonist. It will constrict the blood vessel. Automatically, you should be very careful when you use the drug. It is very costly drug. Thrice daily doses, 5 milligram you can give. But prior to that, try to rehydrate the patient. Very important. Rehydration, rehydration, and rehydration for orthostatic. Elastic stocking in the second thing. Carpeting the floor is the very important thing, which is not mentioned even in your Harrison. But I tell every patient of my Parkinson, it is in my personal, under my care, which patients are actually getting treated. I tell them the commode should be attached to your room and you should be in the ground floor and entire room should be carpeted with a big amount of cushion system. So even if you fall, there should be less chance of development any fracture or any subdural hematoma, which is very, very common in case of Parkinson's disease. That number 3 important point, the video which he has shown, Partha has shown, vascular Parkinsonism and your normal pressure hydrocephalus. Always see to which part of the body is affected. If you find the lower half of the body is more affected than the upper part, think about normal pressure hydrocephalus and march the petit spa, that is the vascular Parkinsonism. Vascular Parkinsonism, as the normal pressure hydrocephalus, will have more predilection for the more lower limb than that of the upper limbs. So upper limb involvement is more common in Parkinson's disease, lower limb involvement more common in normal pressure hydrocephalus, as well as in march the petit spa. That is your vascular Parkinsonism, though the other part will be definitely affected and response to levodopa will not be there with those 2 conditions. Now, never forget about the subdural hematoma, which is a very common thing in our country. Somebody forgets about the trivial history. So, if you find a patient has come, always go for a neuroimaging to exclude a subdural hematoma. That is very, very important. Never forget about the very important continent in the Indian subcontinent. In Indian subcontinent context, you must remember, never forget about neurocysticercosis. Neurocysticercosis presenting in Parkinson's disease has been reported from our country. And one of the patients was in the lunatic asylum of Madras, first patient. He has a neuropsychiatric manifestation and Parkinsonian feature. So these are the things I like to highlight. Drugs have been well mentioned. Ankan has done a very nice thing. And Partha is superb. He has shown a lot of things to us. I think in future also, we will have all these things in a very big platform, and Shambo will definitely go with his endeavor, and he is doing a very marvelous job under guidance of an excellent professor and our revered professor, I should say, Professor Santanu Tripathi, who is associated with me for more than 3 decades. With these few words, I'd like to make an end of this session, and thank you very much for joining. Over to Dr. Shambo for his final comment. Thank you.
Dr. Rai, I just wanted to, Dr. Mrinal Kanti Rai, regarding the slide that Dr. Shambo had shown in that threshold levels, the akinesia threshold and the response threshold of this thing, that keeps on shifting with the progression of the disease. Okay, the akinesia threshold comes down, the window becomes narrow, and then in the extreme right hand side panel, both these come down. So how the adherence, good adherence at the beginning when you diagnose and start the therapy, levodopa therapy, how this process, okay, of progression of the disease, whether good adherence can actually delay the progression of the disease. What is your take on that?
I understand your question. The point is that every Parkinsonian patient is an individualized patient.
Right,
All
right.
Parkinsonian would not respond in the same way. Some patient will develop the fluctuation after starting of levodopa in 3 years, 4 years. Some will not develop even after I have got my patient, because the book will write many things. But in your practical life, some of my patients, even after 5 years, 6 years, they are not having any sorts of dyskinesia. They are doing like that. One of my brother-in-law, he died very recently due to corona. He was the vice president of Bajaj. Very sadly, he died of corona actually. He had Parkinson's disease. And he was taking this advanced Parkinson, but he did not have any dyskinesia. He did not have any, in spite of 9 years of levodopa therapy, he did not have any dyskinesia. I can tell you from the very close point relative. So what I tell, this threshold level is a graphic representation of the overall disease process. Even if you start the levodopa, in the textbook, it is usually in the 4 to 5 years, the whole graph should come down, threshold level come down, and it is in generalization. But mind you, individualization is very, very important.
Absolutely.
So it is not, every patient will not do like that. Some patient will show early, some patient will show late, even if you start the levodopa early in this case.
That's great.
Am I clear?
So, Dr. Partha, very quick comment.
I just wanted to add to Professor Mrinal sir's comment. First of all, the point is the dopaminergic model is an oversimplification of the entire process that's going on inside the brain. As Shambo said, the direct and indirect circuit cannot be the only working there. It's an old model that we have used traditionally. Right. There is so many other neurochemicals that are at play out here. Dyskinesia is not from levodopa alone. There is histaminergic, serotonergic, noradrenergic, and so many other unknown chemicals that are also working. And there's a constant shift in that accelerator gear that Shambo tried to
Brake
show
and
us.
the accelerator, yeah.
The dyskinesia is basically definitely due to levodopa. This presence of dyskinesia confirms that it's levodopa is still working. And with time, when you're diagnosing it on the DAT scans, we didn't get to imaging, there is at least 50% dropout of the dopaminergic uptake neurons. That's when you will get the first symptom. 50% is no longer working.
Yeah.
And with time, there is the capacity to absorb the levodopa from the blood into the brain cells, then slowly release it with time, becomes less and less efficient. So I have patients who have to have levodopa every 2 hours, unless they take a continuous morphine infusion. That's alternative. And I have some high court lawyers in Kolkata who take swigs of levodopa dispersible, levodopa carbidopa dispersible before they go into the courtroom,
right,
before they start pleading. And a few of them I have seen. So that's how it works. So that's the more than just levodopa, and dopaminergic neurons, which we think are putative, are losing the capacity to store, because you have to store it and then gradually release it. So in a sustained fashion, in tandem with the other circuits. So that's disturbed. And that's we're getting all that Professor Mrinal was just talking about. Thank you.
Thank you, sir. Thank you. So I think we have also fortunate to have Professor H.S. Pathak, sir, who is now the chairman of Indian College of Physicians West Bengal chapter. So it is a real honor for us, Inovocare Academy, to have you also, sir. So please give your comment on today's program.
In one word, I will mention the program par excellence. Really, a lot of things could be learned, and all of you have presented such the things in such a way, and most of my students have also joined, and they are also.
I am your student, sir.
Oh,
I am your student. So your first speaker is your student.
It's
the
my
third speaker
pleasure.
is your son.
So
I do not know about Shambo.
One student, one son, and one disciple. So you are a proud person.
Right,
Yes.
right. I feel proud for Professor Partha. Really, he had been a diligent student right from medical college, and he has he has attained such a highest position in overseas.
All by the grace
so we
of
are
God.
all very proud.
God Almighty, my parents, and my teachers. But Professor Madan Mohan has also contributed to my career.
Right. We
I
had
first started. Yes, we were scared of him, honestly. He's such a disciplined man.
Right.
Very scary. At time punctuality was a real issue. No, I think honestly, I not because I spoke, but the point is the standard of today's meeting was no different from International Movement Disorder Conference. And I mean it, not because I spoke here, no difference. And I would encourage our students, there's only few left, to apply for a free membership of the International Movement Disorder Society. It's free to Asia, Oceania. That's one. And the second thing, the American Academy of Neurology will give free membership and the Continuum Journal to everyone who is in training, MD and DM neurology. So please apply for those two. Not many things in this world is free these days, but 2 memberships and the Continuum Journal and membership of the neurology article comes free with the price. For me, it's too expensive. I cannot afford it anymore. So please make use of the, of all the young people here. I can see a few young names here. Please apply for International Movement Disorder Conference membership and the American Academy Neurology membership. It's, I think, next to nothing for the American Academy and definitely free for the movement disorder. Because it's
Thank you, sir. Thank you very much. And I think we should not stand between the marriage anniversary dinner of Professor Mrinal Kanti sir.
It's okay. It's okay.
Or any more. We are really sorry, sir, for this delay.
No, it's okay. It's okay. This is more than anything. This academy to me is something. I know it very well. Shambo knows it very well. Because my first love is with books, then with anything else.
Sir prepared my talk on ataxia. sir and me sat in a Zoom and prepared my
No,
ataxia
no,
talk.
Partha, you did it very nicely. Ataxia, I just told you should do it that way. You have done
Yeah,
it very
and
nicely.
no, you helped us in the Corona time. Everybody was depressed and everybody did not know where the world was going. You held it together by putting in academics. As I think Professor Pathak was saying yesterday, that everybody was busy running around and worshipping Goddess Lokhi, and then you brought Goddess Saraswati into the API, and that, you know.
Oh, you remember my comments. Professor Rai, you remember my comments, right?
I
Thank
remember
you.
everything you say, sir. I listen.
So, really, regarding today's program, Dr. Shambo needs really great compliments because in such a short notice, he organized this program, I think, in 2 days' notice.
Yes.
And Ankan could get 1 day's time to prepare all these things. I don't know how he did it.
Very good.
So,
Very bright.
It was excellent, sir. It was excellent. We are really thankful to Dr. Ankan because such a short notice he had prepared such a beautifully. Thank you, Dr. Ankan Pathak.
He worked till 2 o'clock in the morning yesterday because I left him at 12:30 at night. And after that, he did the whole presentation.
So
Very good.
thank you all.
Inspirational.
Thank you. So we have to end today's program.
Yes,
we are
yes.
really thankful to Professor Mrinal Kanti Roy, Professor Santanu Tripathi, Professor H.S. Pathak sir. Today, Professor Shivendu Ghosh sir also had joined.
Shivenda came. Yes, I saw him. He's gone.
And we are really thankful to Professor Partha and Dr. Ankan Pathak for this wonderful deliberation. So
Thank yourself.
may I request now Mr. Rohan Tripathi, who is the mentor of this Inovocare Academy. Please say a couple of words and we can say good night to all of you.
Thank you, Shambo, for doing such a good educational work for everybody. You deserve a special word of praise.
Thank you, sir. So, Rohan, are you there? I think there is some technical issue from his side. Okay, so thank you all. Thank you. And once again to Dr. Mrinal Kanti Roy sir, happy marriage anniversary, and we need your support in our future endeavor. All of you have a good night. Thank you. Thank you all.
Good night.
Thank you.
Bye-bye.
Stay safe, stay well, and away from Omicron.
Right.